In a typical echo session, we would discuss 7, 8 patients, and then 15 minutes or so, either I would give them a lecture or our psychiatrist would give them a lecture on some aspect of hepatitis C. It was important not to make echo a 1-hour lecture. So as I did this week after week, I found that in 1 year, they became complete experts. And in 18 months, the wait in my clinic fell from 8 months to 2 weeks.
And now, from San Francisco and the UCSF Rosenman Institute, the Health Technology Podcast with your host, Christine Winoto.
When I first sat down with Dr. Sanjeev Arora, I was struck by his quiet determination and the deep sense of purpose that drives his work. Dr. Arora is not just a renowned liver disease specialist, he's a social entrepreneur who has spent over 30 years creating life-changing solutions to bridge some of the most critical gaps in healthcare. As the founder and executive director of Project Echo, Dr. Arora has revolutionized the way we think about healthcare equity. His vision was simple yet profound: to democratize specialized medical knowledge so that no one, regardless of where they live, is left behind. What started in 2003 as a small initiative to address hepatitis C in underserved area has grown into a global movement, with Project Echo now operating in 194 countries, empowering health workers and logging more than 4 million attendances. What really struck me during our conversation was the heart behind his mission. Dr. Arora's passion for equity is not just about treating diseases. It's about empowering local communities, addressing systemic challenges like education and climate change, and building a resilient network of knowledge that span the globe. In this episode, Dr. Arora shares how a single patient story inspired Project Echo, the challenges he faced in scaling such an ambitious model, and the transformative impact it's having on millions of lives. He also offers a glimpse into his bold vision of reaching 6 billion people and explains how shared expertise can strengthen entire communities. Listening to him, I could not help but feel inspired, and I hope you will too. Thank you for joining me this morning, Dr. Arora.
Well, thank you, Christine, for the kind invitation.
I had the pleasure of meeting you at our last symposium, and I was very fascinated with the work that you've been doing and you're doing and what you did. And I like to start with a lot of my podcasts is about somebody's journey, the personal journey. What are your process, like your journey that take you where you are today. And I think that's always interesting to hear.
Well, thanks again, Christine. So I was born in India and came to the United States in 1980 and have lived here almost all my life and did my gastroenterology training here in Boston, Massachusetts. Subsequently moved to the University of New Mexico, where in the medical school, I'm a professor and also founded the ECHO project in 2003. But the story of ECHO actually starts with a patient, one patient that I saw in my clinic at the University of New Mexico.
What drew you to come from India to the United States to do medicine?
Yeah, and when I came in 1980, I was in this unique situation that all my studies were in English with all the blood tests and medicines that I was reading about, but many of them were not available for my patients. And I really wanted to learn the very latest in medical science. I wanted to be at the cutting edge of where medicine was practiced. And also, I wanted to be trained in a way that I could be one of the best doctors in the world. And so it is that training and the ability to practice medicine with the latest knowledge, the latest technologies was an extraordinarily important draw for me. To leave India and come to the United States. I came with the intention of going back after my education, but certainly found this an incredibly important place to make global contributions, and so decided to stay.
Being here for most of your life, and you had the experience being in India, being a physician as well. What are the things that that experience that you were in India that kind of shaped your thinking about being a physician here in the US?
I think one of the things that always stayed with me throughout my 40 plus years in the United States is the idea that the vast majority of people in the world don't really have access to the right knowledge at the right place at the right time, and therefore cannot get the right care at the right place at the right time. And actually, millions of deaths occur unnecessarily, even when the diagnostic tests and the medicines that you need to treat these diseases like diabetes and hypertension and high cholesterol, or to diagnose cervical cancer early or breast cancer early, these are freely available in every country in the world, even in remote Africa. But without the right knowledge at the right place at the right time, a lot of unnecessary deaths and suffering occurs. People get disabled due to disease unnecessarily. And of course, young mothers die during delivery, and only less than 15% of the patients with blood pressure get treatment in the world, and develop strokes and kidney failure at a younger age because of lack of treatment, which then not only affects them and their quality of life, but affects their family, their future generations. And so the absence of this good healthcare is a profound problem. And having grown up in India, I was exposed to it firsthand.
Maybe this is a good segue to share with us about your work at Project Echo, where the idea came about, and how is that going back to tie it back to your experience when you were in India that you kind of shaped who you are to make that project a reality as well.
In 2001, I had gone to my clinic here, and there was a 43-year-old woman sitting there. And in the room with her were two children. There was a 14-year-old boy and a 9-year-old girl. And I asked her, "How can I help you?" And she said, "I have hepatitis C and I want treatment." So I said, "Of course, we'll do that. How long have you had it?" And she said, "I've had it for 8 years." So I said, "Why did you not come earlier for treatment? I've been here treating patients." And she said, "I called your nurse and there's an 8-month wait to see you." As you may be aware, there are very long waits to see specialists in the United States for people who are of low income. And so I said, "Of course, I know that my clinics are backed up, but today it's 8 years since you found out. Why did you not come earlier?" And she said, "I called your nurse and she said, I would have to make 12 trips while I was getting this chemotherapy-like treatment of weekly injections and pills. And with being a single mother, there was no way I could take so much time off work because I live 200 miles away. I would have to drive 200 miles each way, 12 times, taking so many days off work. So I decided not to get treatment." So I said, "What made you come today? What changed for you?" And she said, "I'm having pain here in the right upper side of my abdomen." And I did an ultrasound of her liver, and she had a cancer of her liver halfway between a golf ball and a tennis ball. And now she was willing to come as many times as we wanted. Her children were older. But the issue was, it was too late, and she passed away 6 months later, leaving these two children. So I was saying, why did she die of a disease that I knew how to treat? We could have saved her life. I live in the United States. All the medicines are there. All the diagnostic tests are there. It's not that I couldn't get the medicine for her. The reason she died was the same as I mentioned earlier, the right knowledge didn't exist at the right place at the right time, and she couldn't get to it. A bigger problem I was immediately facing was that in New Mexico, which is a state with a population a little bit over 2 million people, 28,000 people had already been diagnosed to have hepatitis C, and only 1,500 had been treated. There were also 2,400 prisoners who had been diagnosed, and we knew their names, but not a single patient had been treated, not one. And they were coming to see me when they had cancers or dying of cirrhosis of the liver, but I didn't know what to do. I was working all the time. I was treating a few hundred patients, but how do I get to these 28,000 patients? So I developed the ECHO model to democratize my expertise. I said, it's not about sharing my knowledge. It's about democratizing the implementation of my expert knowledge. And so that's how I started ECHO. And of course, we later have realized that 6 billion people, 3/4 of the world's population today, does not have the right knowledge at the right place at the right time and cannot access good care. And it's not just a lack of medicines or anything of that sort. And these people live in Africa and in rural India and in rural China and many, many, many parts of the world in Latin America, where they have to suffer from these bad outcomes because this knowledge gets monopolized and concentrated in places like UCSF and University of New Mexico and sort of gets trapped.
Mm-hmm.
So I thought I would figure out a way to release this to create more equity in the world.
And how does Project ECHO, like you're saying, democratize your knowledge?
So what happened is that because there were 28,000 patients, they were living all over New Mexico, I developed the ECHO model based on 4 key principles. First was to use technology to leverage my expertise. But it wasn't enough to leverage my own expertise. I needed a psychiatrist, I needed a pharmacist. As you know, care for complex diseases is multidisciplinary. And they didn't have psychiatrists or gastroenterologists in rural areas. So I said I would use technology, one-to-many video conferencing, which we use routinely today in Zoom and Microsoft Teams. But there was no such thing in 2003 when I launched ECHO. So I purchased a used telecommunication bridge from Polycom, put it in the basement. Since there was no cloud, I said I would use this to democratize my expertise. The second key principle of ECHO was sharing best practices. So I went around the state of New Mexico. In my car, I would drive, talk to doctors in rural communities and say, look, your patients are dying of hepatitis C. They don't have access. I would like one of you, not all, there may be 50 in the room in a medical staff meeting. I would say one of you should step up to become an expert in this disease to help your community. And I would give them lectures on hepatitis C. But usually after the lecture, they would say, no, this is too complicated. This is like light chemotherapy, and we are general practice doctors. We can't do that. It's too risky for us. But I found 21 who were at least interested, but were concerned. So I asked myself, how did you, Sanjeev, become an expert in treating hepatitis C? So when I did my fellowship in gastroenterology in Boston, I would see a patient present to my professor. I would see another one present to my professor. And I did this again and again for 2 years. And after 2 years, they started calling me a gastroenterologist. I said, aha, I'm going to use this model to create new hepatitis C specialists in New Mexico without them doing residency programs and fellowship programs. But they would join me once a week in the afternoon at around 3 p.m. every Wednesday and present cases to each other. So we call the third principle case-based learning, all teach, all learn, and iterative guided practice. So every Wednesday afternoon, these clinicians, they were doctors, some of them primary care doctors, some were nurse practitioners, some were physician assistants, and they would join once a week on Wednesday at 3 p.m. and present cases of hepatitis C to me, my psychiatrist, my pharmacist, and to each other. And they blocked off that time on their calendars from clinic. In a typical echo session, we would discuss 7-8 patients without their names or any identifiers. And then 15 minutes or so, either I would give them a lecture or our psychiatrist would give them a lecture on some aspect of hepatitis C. It was important not to make echo a 1-hour lecture. So as I did this week after week, I found that in 1 year, they became complete experts. And in 18 months, the wait in my clinic fell from 8 months to 2 weeks. Being a professor, I started doing research in it. And that brought me to the fourth principle of echo, is to track outcomes. So I started doing research, and the first type of outcome we tracked was the self-efficacy of these primary care clinicians. And we showed, wow, they actually gained enormous confidence and felt they had become complete experts. But we also found something interesting. Echo was producing joy of work for them. It was reducing their professional isolation, increasing their professional satisfaction. And of course, it was improving access to treatment. In fact, in 18 months, the wait in my clinic was 2 weeks. And over the next decade or so, we treated 10,000 patients of hepatitis C, and anybody in New Mexico could get treatment for hepatitis C close to their home because these were widely dispersed across the state. All of this was good, but the global massive rollout of echo did not start until 2011, when we published a paper in the New England Journal of Medicine. So in 2004, we had got a federal grant to do a head-to-head study of rural primary care clinicians and prison doctors treating hepatitis C with this chemotherapy versus the University of New Mexico. And in the New England Journal of Medicine, we were able to show that these rural doctors, nurse practitioners, could get exactly the same outcomes as us if they participated in echo. This paper was truly a game changer in a way that instantly I started getting emails from all over the world saying, look, we want to do this for diabetes. We want to do it for HIV in Africa. We want to do it for mental health disorders in the US, for treating addiction, for tuberculosis in India, and so on and so forth. And the global rollout of echo started.
That's really fascinating. And it's really amazing to hear when you open up your knowledge and sharing with those who can make a direct impact. It's so powerful. And the fact that also your generosity to share your knowledge with those who can make a bigger impact than just the patient who see you. My next question is that when you got all this inflooding interests, how do you deploy it so that more and more people can learn from your pilot in a larger scale by then already to make it even bigger?
So the first thing I did was I started applying for philanthropic grants and federal grants to people all over the world with the argument that, look, we can change the world if we create thousands and thousands of these networks around the world for different disease areas. The first grant I got was from Robert Wood Johnson Foundation. There was a competition called Disruptive Innovations in Healthcare that could change healthcare globally. And we got a $5 million grant to test the idea whether we could use it for a lot of different diseases. And then to test the idea that we could spread it to other universities. So we started doing it for 15, 20 disease areas in New Mexico. And then we taught University of Washington, then Harvard, then University of Chicago. Subsequently, we taught MD Anderson and Johns Hopkins and UCSF and Stanford and so on and so forth. And in 2013, I met with Eric Wan, who lives in your area. He's the founder of Zoom. And I mentioned to him that, look, the whole world is talking about equity. And the predominant means of creating equity in the world is sharing resources, money, grants, etc. But the physics of knowledge and expertise is different from the physics of material resources, in that when you share money and I give you half, you're only left with half. And I'm left with half. But when I share my expertise with you and you share your unique expertise with me, because the learners in ECHO have the unique cultural competence, they know the economic constraints, they know what equipment is available, they know what medicines are available. So together, when you share this knowledge in what we call all teach, all learn, so you have 20 plus people sharing their knowledge with each other, listening with respect and empathy and kindness, and building community, new knowledge is created. So the physics of knowledge is by sharing it grows. So I was telling him that, look, the best way to create equity is to democratize the implementation of best practices, for which there are many people in the world who want to do that, because they want to have greater impact on the world with their expertise. And I told him I wanted to help 1 billion people. And he was willing to give me a Zoom license so that I could share it freely with the whole world. Give other people who wanted to democratize their expertise a Zoom license to share their expertise. And now there was the cloud, the Zoom cloud, which allowed us to do all this work. And currently we have 450 hubs. These are all these major universities like Stanford, UCSF, etc., in the United States, and not-for-profits like American Cancer Society, like American Society of Clinical Oncology, that, they use ECHO to democratize their expertise, and American Academy of Pediatrics to improve children's health. And globally, we now have 1,320 hubs working out of 70 countries with 6 million learners in 209 countries and areas. And it's rapidly growing in an exponential way. We have close to 7,000 networks operating of the kind I described earlier. And we have impacted the health of between 200 and 300 million people. But we have just begun. We have developed a technology platform called iEcho, which allows us to track ECHO across the world, track the unique learning journey of every learner, no matter which part of the world they live in. They could be in rural Africa. And digital certifications for people to do important work. Plus, evaluating, allowing these hubs in South Africa and in Zambia to use echo to evaluate the effectiveness of their work and assess its impact. But also, the most important thing, of course, here is it allows ministries of health to use the echo model to achieve their priorities, their goals, with speed, with scale, with much higher quality and at much lower cost. The government of Kenya has, in Nairobi, has just published data saying it was costing them $800 to train one HIV doctor in Western Kenya. And now it's costing them $21. And it's more effective because this is the drip irrigation method of training. The usual training models in the world, Christine, involve getting a doctor to your place, training them for 5 days, and then hoping that 6 months later, they still have all the knowledge and are implementing that knowledge. And it's hard. It's like the way I describe it is, Christine, if you have a garden in your house in San Francisco, if I told you you could water it for 5 days continuously, once a year, what is the chance you're going to have good flowers 6 months later?
Right.
So this is what we found is the drip irrigation method and the guided practice is much more the organic way we learn. So if you wanted to teach your daughter to drive a car, you just can't give her lectures on driving a car. Sit next to her and do guided practice. That's what Echo does. And so we have developed a new capacity building model for the world. And it is the most evidence-based now. We have more than 600 peer-reviewed publications showing that Echo is effective in every geography that it's been applied.
I think it's really amazing. And I think you not only you democratize the knowledge, but you also create a community.
Yes.
Where one can learn from another. And oftentimes when people who has more knowledge, I'm sure they don't feel that they're just giving away their knowledge, but they also get knowledge back.
Yes.
And one of the things that I'm asking you is, how do you convince somebody who has a lot of the knowledge when they are busy with their practice, who have 8 months waiting period to see them, to convince them like, you can learn something by giving back?
Yeah, you're asking first of all, your comment is so insightful. What you realized is, just intuitively you realize by listening carefully, that what creates real value for patients, for clinicians, is not just the knowledge. It is the love and respect and kindness and empathy and community building that we do amongst doctors and nurse practitioners and community health workers to share amongst each other. That is the energy that makes Echo grow, because we are all hungry for community. But the question you're asking is really critical. Knowledge is money. Knowledge is fame. Knowledge is power. So not everybody wants to democratize that. In fact, the vast majority of experts in the world in every field use it for one of those three purposes: money, fame, power. And the business models are all geared around monopolizing knowledge rather than democratizing it. But what we found was that there is a large number of people in the world for whom money, fame, and power isn't their predominant motivator. What they want is, they think a little bit like I was thinking. I was saying, look, I've become a world expert in hepatitis C, and when I retire, it'll all go out of circulation. And when I die, it's going to go into the grave. This is a gift I've received. how can I use it to have as much impact as possible? And what I found, which was the most hopeful thing, is the world is flooded with people like that, who assess their contribution not just by how much money they make, but how much impact they have. And many, many people who spend a lot of their time making money, also at the heart of it, in the end, want to use that money to have more impact. So what we did is we said we would, just like I was democratizing my knowledge to treat hepatitis C, I would democratize how to do echo. So we set up a 2.5-day training program. And believe it or not, we trained Stanford and Harvard and UCSF and all of these places on this 2.5-day model. And we offer them the Zoom platform for free. And we offer them this iEcho platform at no cost to them. So we don't charge anything for our service. We give everything away to everyone in the world for free. And sometimes they even offer us money. We say, we won't take it. You have to pay it forward, okay? And all our work is supported by philanthropy. But we barely scratch the surface. We may have touched 200 million, 300 million people, but we want to help 6 billion. And we are on our way. But we are always looking for collaborators and invite you to join them. What I can say is there was a Nobel Prize winner. His name was Albert Schweitzer. He got the Nobel Peace Prize. And he said, I don't know what your destiny will be, but one thing I do know. The only ones among you who will be really happy are those who have sought and found how to serve. And I found this to be true in my life, that service to others produces enormous joy. And these specialists, they can see it. They don't have to do echo for 3 years to experience it. It's pretty quick when you see what we call force multiplication. That is, they are able to exponentially 10 times improve their impact. So if they were helping 100 patients of a disease a year, they could help 1,000, 2,000. So that's what attracts them. That's what attracts specialists and experts in different areas. Now we are testing it in climate change. We have huge number of echo projects now, more than 100, just in education, to mentor school teachers, to be better teachers in math and science and literacy, etc., etc. So the model is applicable to a wide variety of places wherever knowledge tends to get concentrated and locked up behind patent walls or behind economic interests, because fee for service is associated with billing and collections. But the economic cost to the world is huge. The healthcare costs, because when a loved one of somebody gets paralyzed or disabled, the economic cost to the world is enormous.
Right, the impact, the trickling impact for
Yes,
the family, the community.
Yes.
That is sometimes the cost that oftentimes is not measured.
Yes.
And then people somehow tend to discount when it's not the direct cost.
Yeah, and the reason you started this podcast is exactly the same. Mm-hmm. You wanted to serve. You wanted to serve a broader audience than the students you were interacting with at UCSF. This podcast can be seen by anyone in the world, or it can be understood. And I'm sure you have lots of very interesting people who come and share ideas. And so I'm excited to have the opportunity to speak with you.
Well, thank you for sharing this. That's what your work is. I know it's inspiring, but hearing it from you in more detail, the your journey, I think, is really amazing. One last question before I let you go is that when you started this Project Echo in 2001, how, technology is not there. What are the 3 surprises that you did not anticipate?
I think the one surprise was, as I mentioned earlier, the number of people who just came out of the woodwork to tell me that they wanted to use the model for greater impact on humanity. So you can imagine, we have learners in 209 countries, territories, areas. There are only 193 UN member countries, okay? So literally every place, there are people who want to use a model. Now, they may not have the wherewithal to create the whole infrastructure and the tech software or buy the Zoom license, but they have the heart for it.
Mm-hmm.
So it was very, very surprising and encouraging. The second, I think, in the United States, the current fee-for-service model does not at all support Echo, because the only way a specialist gets paid is when they see the patient. So all the economic forces play against Echo in a sense. But yet, it has been spreading widely in the United States, thousands of networks. Because the people themselves, the experts, their heart is in a slightly different place than the economic forces that drive. And I can assure you that is also true for UCSF faculty there. I'm also surprised how long it takes to change anything in the US healthcare system, where there's enormous shortages of experts for underserved people. Most poor people don't have access to good mental health care. Most children with trauma cannot access a psychiatrist in this country. And yet we have an enormously difficult time changing our healthcare system so that it is better aligned to provide high quality care for a fully trained workforce, which is mentored and supported. One of the key problems in the healthcare system is knowledge is increasing at an exponential pace. And the NIH published a delay of 17 years for this knowledge to reach the last mile of care. What does that mean? That means thousands, tens of thousands of patients die unnecessarily. And the workforce has no way to get mentored and trained on a continuous basis. We have one. As I mentioned, everybody in the US government recognizes it is the most evidence-based model for capacity building and improving outcomes. We have more than 80 publications showing that Echo improves patient outcomes, 9 showing that the health of the community improves. But it's very difficult to change the reimbursement patterns so that it's more aligned with the needs of patients, the needs of training for healthcare providers in rural underserved areas, and to democratize the expertise that has locked up in these amazing universities. So that was also a surprise, that there's a huge amount of resistance. At the Rosenman Institute, you have certainly seen when you hold these conferences, people describe the challenges that there are. Well, to me, that is a surprise that we, as the most amazing, generous country in the world, which is completely flooded with the spirit of generosity, we still have a very hard time responding to the healthcare crisis in this country, for which there are imminent solutions. Mm-hmm. But economic interests of different stakeholders come in the way. Yeah. And it's a barrier. So that is a negative surprise too. Yeah. Lots of the story of Echo has been full of positive surprises, and what you used this term in the beginning of this podcast. What drives Echo is the spirit of generosity that exists in the world to a very large extent.
And I hope more people hear about that and get that spirit to be contagious. And that's when the world is moving closer to a better world, I think.
Yes.
So, well, I know our time is up. I wish I have more time to ask you with more questions, but maybe we can continue that conversation on the next podcast. But thank you for your time, and thank you so much for your work and the impact that you have accomplished. And I wish that you reach to that 6 billion number in a very near future.
And thank you, Christine. It's been an honor and privilege to speak with you. And thank you again for the kind invitation.
Thank you. Thank you for tuning into today's episode of the Health Technology Podcast. We hope you found the conversation insightful and inspiring. If you enjoyed this episode, please take a moment to subscribe, rate, and leave a review on your favorite podcast platform. Your feedback helps us continue bringing you the latest in health innovation. Stay connected with us on LinkedIn and Twitter for updates on upcoming episodes and more. Until next time, keep pushing the boundaries of what's possible in healthcare. I'm Christine Minato, and thank you for listening.